Hi, my name is Jamie and I'm an X-ray tech student at El Centro College. Today we're going to be analyzing a AP externally rotated shoulder. This image here is of a 54-year-old female who was brought into the ER after a car wreck. She was complaining of shoulder pain, so the doctor ordered some shoulder projections. Now she did walk into the X-ray room, and I greeted myself and let her know that my name is Jamie and I was a X-ray student at El Centro. I did get her date of birth to ensure I had the correct patient, and I explained the different positions for the projections and let her know that everything was going to take about 10 to 15 minutes. Now, after observing her and speaking with her, I decided to do all the projections with her at the upright wall bucky. So I did use the wall bucky with the grid. I made sure my tube was detented and it was at a 40-inch SID. I demonstrated to her the positions for the projections and had her mimic them with me to ensure that she was able to do all of them. Now for the AP externally rotated, I made sure to ask her to turn her hand out externally until her palm was facing anterior, so forward. And I then positioned her at the IR and make sure to center my shoulder. I brought the central ray 1 inch inferior to the coracoid process. I then collimated down to the part and then put my left marker within the light field. Before walking away, I let her know that when directed, I was going to tell her to hold her breath and to hold still. I then placed a standing shield in front of her to make sure to shield her from the waist down. So I walked back to the control panel and I did use a AEC, and the AEC shot at 80 kVp at 10 MAS. My exposure index was at 293, which was in the hospital range. So this is the image that we did. So let's go over some of the anatomy here that will correlate with the image criteria. So we have this superior scapular angle here. This is our clavicle. This would be our mid clavicle. We have our greater tubercle here. This is our lesser tubercle anterior to that. This is our humeral head. This is our humerus. We do have the coracoid process. This is, of course, here our scapula. This would be our medial scapula border. This here would be our lateral scapular body. This is our vertebral column here. And of course, this is our scapular body here in this area. So going over some of the image criteria and the positioning. So the first is a scapular body should have minimal transverse foreshortening. So this would be our transverse here. Half of the scapular body without thorax superimposition. So here is our bony thorax. It should be positioned only half of the scapular body. The clavicles with minimal longitudinal foreshortening, and the mid clavicular end should be positioned right next to the lateral edge of the vertebral column, which is here, vertebral column, lateral end, and this you can see here, it doesn't look like there's much or none at all longitudinal foreshortening. Now, in order to accomplish this, you want to make sure that the patient's mid-coronal plane is parallel to your IR. You want to make sure that there's no rotation. Rotation would superimpose your scapular body completely. And here you can actually see it's a little bit more than half of the scapula, but mostly I got exactly what it is that I needed. Now the scapular body should be without longitudinal foreshortening, and the mid clavicle should superimpose the superior scapular angle. So this is our mid clavicle here. This is our superior scapular angle. Now you can see right here where they are superimposing each other directly. Now, if you was to have any tilting, whether forward or backwards, this would bring your superior scapular angle. So if you were to be tilted anterior. So if their shoulders were hunched forward, that's going to bring their scapula body up, and they would not be superimposing. Now, if you had your shoulders back too far, it would bring your the superior scapula angle down. So that would indicate whether or not there was anterior tilt or posterior tilt, which here you can see that they're actually superimposing each other the way that the image criteria needed it to be. The greater tubercle should be in profile laterally, and the lesser tubercle should be anterior to that. The humeral head should be in profile medially, and now in order to obtain this, your epicondyles need to be parallel with the IR. So it's very important that when you externally rotate, palpate your epicondyles, make sure they're parallel to the IR. That's going to give you your greater in profile laterally and your humeral head in profile medially. So what needs to ensure what's in your image here, you want to make sure that your glenohumeral joint is here, which we have that here. Our clavicle is in the picture, which is here. You want to make sure the proximal humerus is also in your picture. Your superior scapula are also included in the exposure field, which everything is here. I do want to talk about transverse foreshortening and what causes that. So Martinson states that when we do an AP scapula projection, naturally our scapula sits at a 35 to 45 degree angle, which brings our lateral border more anterior to the medial, so you get this oblique. And whenever the anatomy is obliqued in the body, it's going to give you foreshortening. So your IR is parallel to your perpendicular to your CR, and the part needs to be parallel with the IR. Now, in order to lessen the foreshortening, retracting the shoulders is going to be important, because that's going to bring this lateral border of the scapula back. It's going to bring it more parallel to the IR, and that would help to decrease some of that foreshortening. So going into some of the errors here, of course, that was one of my errors, was the transverse foreshortening of the scapular body. And what happened here was I did not have her retract her shoulders enough to bring her mid-coronal plane parallel to the IR, which would have lessened the foreshortening. Another error here is my greater tubercle. Yes, it is in profile, but my lesser tubercle is directly below it. This distance needs to be a lot greater than what it is, and it's very, very minimal here. So what happened here is I did not palpate my epicondyles to ensure that they were parallel with the IR. She was actually over externally rotated, which brought this a lot closer. So basically, whenever you have your epicondyles in parallel with the IR, your greater tubercle is going to be in profile, and your lesser is going to be anterior to it at a 90 degree angle, and obviously it is not. So moving on, now there are no artifacts here in my image, which means that I did ask her to remove her bra. There's no bra clamps or metal wiring of her bra. The image, the radiologist's impression stated that there was no radiographic osseous abnormalities, which basically means there was no bone abnormalities found. So there's no fractures or damage from the car wreck. Also, I feel that my contrast was adequate, showing bony detail, which is here. And although this is a suboptimal image from these minor errors here, the transverse shortening and my tubercle distance here, the image did not need to be repeated, and the radiologist was able to still make analysis of the image. So thank you for listening, and I hope you enjoyed the presentation. Thanks. Bye.